Good afternoon, everyone. Really thankful that you're here this afternoon, and want to introduce myself first. I'm Tony Campbell, pharmacist with Wells Pharmacy, and just very briefly, I've been compounding since 2003, and primarily sterile compounding, formulation development, and such. And was going to present today on Sermorelin and specifically on Ipamorelin and Ibutamoren. Those are two new offerings that Wells is offering, and want to give you guys some insight into how they're used, why they're used, and why they might be a better option for some of your patients even currently on Sermorelin or a GHRP. So I do want to take good use of the time here, so we'll get right to it. We got a lot to cover. So these are just some of the things we're going to talk about real quick, just to give you an overview of what this webinar is about. We're going to review some physiologic process of how the growth hormone is released, and then how it declines as we age. The effects of this aging and the symptoms of this somatopause or decrease in growth hormone as we age. Get an understanding of what growth hormone secretagogues are, how they increase growth hormone output, and how we can use them in clinical practice. And just throughout some commonly used dosing protocols that are published throughout the literature, as well as some dosing protocols that have been used in clinical practice for several years. And then hopefully we'll have some time at the end and we can jump on some questions. If we don't get time for the questions, I'm always available through email or a phone call after the webinar. So the first thing we just want to talk about is growth hormone secretion. It's secreted, of course, by the anterior pituitary and released into the bloodstream in episodic pulses. So growth hormone isn't released continually, and it doesn't at a sustained level throughout the day. We can see this by this very simplified diagram here, and this is a really valuable tool to kind of give a very basic picture of how growth hormone is released. We get about 10 pulses a day. They last about as long as up to 90 minutes, generally about 2 to 3 hours apart. Of course, our greatest pulse comes right after the first hour of our deep sleep. And that's kind of the purpose of what we'll get into the dosing of Sermorelin, is why we give it prior to bed. But getting back to this diagram real quick, we'll see that growth hormone releasing hormone stimulates the pituitary to release growth hormone. Growth hormone is only produced as a function of the pituitary. This is very significant when it comes to providing growth hormone directly in some elderly patients in an attempt to increase their growth hormone levels. You provide omnitrope directly, you're not giving the pituitary a chance to even be stimulated. So what happens is you get a feedback, and it shuts off the production of the pituitary to release growth hormone, and you get elevated IGF-1 levels and very super physiologic doses of growth hormone. So we'll come back to this a little bit later, but it's just very interesting to look at this to see the whole negative feedback and how and where growth hormone releasing hormone acts, and as well as the growth hormone inhibiting hormone or somatostatin. And they'll come into play a little bit later as well. So in the younger, these pulses are frequent, they're very strong, and they begin to decline sharply as aging occurs. Generally, by the time we're about 30 years old, we'll see kind of a plateau effect. This is a general population study that they've done, and they find that these are the ranges. So generally, when you reach your third decade of life, you're kind of flattening off, and the amount of growth hormone you secrete on a daily basis is significantly lower as we are in our teens and our 20s. However, what they did find is that although the amount of growth hormone that's released decreases, the frequency or the number of times that there's a pulse does not decrease. And this is very significant because the pulse is still remaining throughout the span of your lifetime, even though you age. It's just that those pulses aren't as strong. So we want to use these products to increase the frequency and additionally to increase the amount secreted during those peaks. And lastly here, these pulses are peak early in the morning hours, generally overnight. They promote sleep, healing, exercise recovery, and natural regeneration. And this is why we want to help increase our growth hormone. Again, these patterns of growth hormone secretion in the younger and the older people. This is just a comparative diagram here. In the young female, you can see that those peaks are very, very high in the young, and then in the older female and males, the frequency, the number of times you get a little peak there, is generally about as frequent. They're just significantly lower. So with those lower growth hormone levels, we come to what's known as come to know as somatopause. So these symptoms very closely mimic the symptoms that are associated with age-related growth hormone deficiency. And this is why it's very difficult to maybe sometimes diagnose AGHD, and a lot of times why using products like Sermorelin and GHRP are very useful, because we know that using omnitrope or using growth hormone has been proved to be very effective and reduce morbidity, mortality, and things like that by using growth hormone in the elderly in these patients. So the idea has kind of crossed over into the fact that these elderly people who have low growth hormone may also get the same benefit that these other patients are with adult growth hormone deficiency. So we do that through a roundabout way by not giving growth hormone directly, but by stimulating your own physiologic ability to produce more of it. So these symptoms of somatic pause, decreased lean muscle, muscle strength, skin elasticity, recovery from injury, those are all associated with old age, as well as the clinical features of growth hormone deficiency. So again, the thought behind this is, hey, this works for these people. Maybe if we give growth hormone replacement, we can help these people that don't have growth hormone deficiency, but they're having these symptoms of somatopause. So along comes growth hormone, and there's been great advantage of this. It's been proven to be effective. It does increase growth hormone as well as IGF-1. It is accepted and it's been widely researched and shown to be very effective. So it can be very, very useful in these patients. It has decreased fat mass and volume for patients. It increases your lean body mass, your skeletal muscle structure, your exercise capacity, cardiovascular function, even your bone density. So overall, there's a lot of advantages. However, there's a lot of disadvantages associated with it as well. There's a lot of potential risk in the literature associated with long-term therapy, unnatural exposure to the hormone, of course, maybe erode your innate ability to produce growth hormone. And this is because it's not controlled by the negative feedback system that we saw earlier. So you get a lot of tachyphylaxis and then reduced efficacy of that. Additionally, the use of growth hormone in the elderly is restricted only to a couple of diagnoses, AIDS and the growth hormone deficiency diagnosis, as well as cachexia and short bowel syndrome. So unless you have one of those diagnoses, you really shouldn't be using growth hormone in the elderly, and certainly not strictly just for age-related somatopause symptoms. So now comes growth hormone releasing hormone, otherwise known as Sermorelin, and then the growth hormone secretagogue therapy. So the advantages to these is that you have pulsatile secretions versus the prolonged square wave release that you see by giving growth hormone directly. These quick bursts suddenly peak just like it would in normal physiology, where your body has quick bursts throughout the day, and then they decline rapidly. And this allows your body to respond to it, not produce more than what occurs under normal physiologic conditions. And then you kind of avoid the whole superphysiologic exposure of growth hormone, as well as the tachyphylaxis and the resistance that you often see. So rather than introduce exogenous and superphysiologic doses of growth hormone directly upon your liver, secretagogues like Sermorelin, they stimulate the normal secretion of growth hormone. And the key to this is that the patient has to have a normal and responsive pituitary. Sermorelin and the peptides that we're going to talk about later are probably not going to be an option for people that have a low functioning pituitary or have any pituitary lesions of that type. So the advantages again, we're going to come back to this and see that this normal feedback regulation by IGF-1 is preserved by using these growth hormone releasing hormones and secretagogues. So you do get some protection against potential overdosing. So we have growth hormone releasing hormones. So these are a group of drugs known as Sermorelin to Sermorelin. You might have heard of CJC 1295. These are all growth hormone releasing hormones. Then you have the ghrelin receptor agonist, or otherwise known as GHRPs, and those are GHRPs 1 through 6, and including Ipamorelin. And then you have some non-peptide secretagogues, and we're going to talk about Ibutamoren. Also included in that are drugs like Sermorelin, Sermorelin, and so all those are growth hormone secretagogues. And what they do is have a function on a part of the body which stimulates the release of a hormone in another part of the body. So all of these do this, but they do it at different levels and through different receptors. We're going to discuss that in just a little bit. First, we're going to get right into GHRH, specifically GRF 129. So this is known as Sermorelin. So as you may be aware, endogenous growth hormone releasing hormone is a 44 amino acid chain. Sermorelin is a truncated version of that. It's the first 29 amino acids, simply because it's been found that only the first 29 amino acids are necessary to elicit a physiologic response of growth hormone. So in doing that, you reduce the molecular weight of this. It's a lot smaller. Still, it's very, very large. The half-life of this is just a matter of minutes. Research has also shown that the use of Sermorelin stimulates the release and synthesis of growth hormone by a couple of different ways. Number one, it increases the number of cells, or the somatotropes, that release growth hormone. In addition, it also increases the amount that is secreted per somatotrope. So it has a twofold approach to increasing growth hormone. Research has also shown that it can increase lean body mass, reduce abdominal visceral fat, and may promote slow wave sleep. So there's a little contradictory studies on whether or not it does promote sleep. Of course, you can have a lot of studies out there that say it does, and others that say that it doesn't. But in the end, really what you're doing is increasing the amount of growth hormone in these patients, and whether or not they sleep better. Because of that, there's a lot of other factors that play into that. So this is just under normal, regular patients who don't have any other underlying conditions or other medications or other, family or life events that may interfere with their sleep patterns. So how do we dose this? Typically, there's really not published information about this is the dose to use in these specific patient population. So it does have a very wide variance. So to say that 100 micrograms is insufficient would not be correct. Is the same it would be to give 500 micrograms would be too much, and that's not correct either. So some patients are going to vary. So you may find that a patient may respond very well to 100 micrograms. Some may respond well to 200. Others may require 300 or 400 micrograms per day. You really kind of got to individualize each patient and find out what their needs are and what their goals are, and how they respond to this. Typically, in your average run-of-the-mill patient, the younger patients, meaning in their 30s and 40s, you're going to get a dose of about 3 to 5 micrograms per kilogram. Considering that they're of average weight, so that equates to about 200 to 300 micrograms given subcutaneously 1 hour prior to bedtime. And we find that this promotes a good release of growth hormone, increases IGF-1 levels, and has very minimal side effects. These patients are generally going to be 35, maybe in their 60s up to 70 years old, in very good health, with a baseline IGF-1, hopefully a little bit more than 90 to 95. And I say that because generally if your IGF-1 levels at baseline are very low, you may have a pituitary issue where the Sermorelin is not going to be as effective if you don't already have a baseline release of this and your IGF-1 levels are low. you may not respond as well to Sermorelin. So if a patient has an IGF-1 of 85, that doesn't preclude him from using it. You just have to adjust your expectations for therapy. And if it doesn't jump up to what another patient did, then you shouldn't be that surprised. And your BMI is going to be hopefully less than 35. So patients over, the BMI greater than 35, they're certainly still a candidate to use it. Just remember that obese patients generally have a reduction in a blunted growth hormone release. So you might want to get their weight under control first before looking to use Sermorelin. Doesn't mean you can't. It's just, again, look at your expectations and don't think that somebody with a BMI of 37 is going to respond the same way of somebody with a BMI of 22. These patients can have no known brain lesions, hypothalamus or pituitary lesions, or untreated thyroid conditions. So this is where the dosing kind of gets a little bit different too. So for women, the dose is generally a little higher than for men of the same age and the same BMI, generally because of the effect that estrogen has on blunting the effect or the production of IGF-1. This goes into some consideration, especially when women are taking oral estrogens. You pretty much blunt any effect at all. If you're giving somebody Sermorelin and the patient's on oral estrogen, you're not going to have any effect. So what we typically recommend is you transition these women to topical estrogens if possible, and they do know that that blunting effect is not seen in the same way as it is with oral estrogen. So you want to transition your patients from oral to transdermal estrogen therapy, and then dose them typically, around that range, maybe 300 to 400 micrograms per day. So your obese patients, I think I touched on that earlier, they might require a little bit more simply because of the effect that obesity has on the release of growth hormone. So the side effects of Sermorelin, get asked this quite a bit. One thing to keep in mind is that Sermorelin was a commercial product, several years ago. It was only on the market for a very short time. It was marketed to be used in children to increase growth hormone, children with growth hormone deficiency. Because of the way that this works, by acting on the patient's pituitary, children, they're already growth hormone deficient, typically have an issue with their pituitary. So this is why it's important that you have to have a functioning pituitary for it to work. This medication wasn't as successful in increasing growth hormone in children, so it was discontinued. However, it's really great to use in the aged because we don't need to get those high levels. So these doses in children were anywhere from 1 to 2 milligrams per day. So we're just using micrograms and getting very, very good results from this. So your most typical side effect is going to be kind of a localized injection site reaction, if you get any at all. And 15 to 20% of patients will experience this. So of those patients who do experience this, more than 90% of those patients are injecting into their abdomen, which we recommend you not do, in or near the navel. What you want to do is change your injection site maybe to the outer upper buttock area, or possibly even on the back side of the arm, someplace else where there's some subcutaneous fat. We find that injecting in the subcu tissue in the stomach and navel region almost always produce a localized rash and itching spot. So then growth hormone secretagogues. So what we do is concurrent administration with the growth hormone releasing hormone, such as Sermorelin, results in a synergistic release of growth hormone from the pituitary. Again, I really can't stress it enough that you have to have a functioning hypothalamus and pituitary for this medication to work. So when you combine medications like GHRP with the Sermorelin, you get a much larger exponential increase in the amount of growth hormone that you release. So These are capable of creating very large growth hormone pulses by increasing the number of somatotropes. And it kind of does this by acting as a form of growth hormone inhibiting hormone antagonist. So it's a somatostatin antagonist to some extent. So these GHRPs, these examples, I've highlighted in down below the ones that we do offer. So we do offer a GHRP2, GHRP6, Ipamorelin, and then Ibutamoren, which is a non-peptide. So these are all growth hormone secretagogues. However, they're all peptides except for Ibutamoren, which is a non-peptide. And we'll get into those shortly. So specifically, we're going to talk about Ibutamoren right now, or Ipamorelin, I'm sorry. So we get into this. So I get asked the question, what's the difference between Ipamorelin and Sermorelin? So as we said, Sermorelin is a growth hormone releasing hormone. Ipamorelin is a growth hormone releasing peptide. And they act on different receptors. They act on the same type of receptors, but a different subtype of receptors. So what this means is that, like we said earlier, growth hormone releasing hormone, or Sermorelin, can increase the number of somatotropes and also increase the amount secreted per somatotrope. Whereas these GHRPs, like Ipamorelin, will not increase the amount secreted per somatotrope, but it can help increase the amount of cells that do produce it by inhibiting somatostatin. So Ipamorelin does have a relatively longer half-life as compared to Sermorelin. It's very potent. The advantage of this is it doesn't affect cortisol or prolactin levels, and it doesn't exhibit a dose-response relationship for ACTH and cortisol like GHRP2 and GHRP6 do. So GHRP6 is also a potent growth hormone releaser. It doesn't have an effect on cortisol or prolactin up to about 100 micrograms. I often find that prescribers are usually using more than 100 micrograms of GHRP2 and GHRP6, either because they're unaware that they maybe shouldn't, or it's just the way that the combo or the mix that we prepare and the way that they reconstitute it turns out to be. So then we have GHRP2, very similar to GHRP6, is a little bit more potent than Ipamorelin. It's about 3 times more potent than Ipamorelin, and it's about 7 times more potent than GHRP6. That just means to say that it takes a lower dose of GHRP2 to elicit the same response as you would get from a GHRP6 or Ipamorelin. So 100 micrograms of GHRP2 is not equivalent to 100 micrograms of GHRP6. If that makes any sense, but it would be you get the same response with the lower dose, basically, is what I'm trying to say. But the efficacy, they do find that GHRP6 is a little bit more effective than Ipamorelin or GHRP2. So the dosing of these, we'll get into this. So most studies show that the saturation dose of these receptors is about 100 micrograms for GHRP. We do often recommend that you kind of maybe round up to at least 150 to get the full benefit, of the drug. You really only get another 50% increase in efficacy by doubling your dose or going up. So doses, what happens when you use too much GHRPs, you can induce a little bit of sensitization because these cells do become tachyphylactic after a while with chronic use, and then you're going to get a decrease in growth hormone production and then a subsequent decrease in IGF-1 values. So to fix that problem, we do recommend cycling, either short-term or even long-term if you want to give it for 3 to 4 months and then stop for an entire month, or just kind of use your break designed into your protocol by doing 3 weeks on and 1 week off. Or alternatively, some people use just 5 days a week, and they take the weekends off. So this is a comparative chart for the GHRPs. We can see that the GHRH there at the bottom with the circles, doesn't release quite as much growth hormone as compared to, say, GHRP2. You can see the difference in the curve values there, and that's giving a 1 microgram per kilogram dose. So that's it's very, very kind of a low dose. If you figure a 70 kilogram person, you're really only giving 70 micrograms there. So it does, like I said, it doesn't take 300-400 micrograms in all patients. And then alternatively, here this is comparing GHRP2 with Sermorelin, and you can see the difference in there between GHRP2 and Sermorelin on the amount that's released. And you can look at these slides a little bit later and kind of digest them a little bit more than we have time for now. So Ipamorelin, what this is a pentapeptide. This means this has 5 peptides on it as opposed to the 6. It does have a little bit smaller molecular weight than the GHRP2 and 6. It does act very similarly to GHRP2 and 6 by acting on these GHRP-like receptors. It's been touted that Ipamorelin is the most selective growth hormone secretagogue. And what that basically means is that GHRP2 and GHRP6 have some cross sensitivity with prolactin, luteinizing hormone, and cortisol, ACTH, whereas Ipamorelin doesn't have that. So that's why they kind of report this as being the most selective, because it doesn't have any of that cross sensitivity reactions with other receptors. So it's a growth hormone releasing inducer, meaning it's a ghrelin receptor agonist with very high specificity. It suppresses somatostatin, which in turn increases somatotropes, which is what we want, which in turn increases growth hormone release. The advantage of Ipamorelin over GHRP2 and 6 is it doesn't have that hunger-stimulating property that we often find with GHRP6 and sometimes GHRP2, because it doesn't accentuate the release of ghrelin. So you're not going to get that hunger feeling when you give Ipamorelin. So the patients that you might be using Sermorelin with a GHRP6 and say, I can't really handle the hunger issues, using Ipamorelin in its place is going to help with those patients that have that issue. So again, in the literature, there's no clinical effect on luteinizing hormone, prolactin, FSH, or TSH. There's a slight increase in cortisol, but that increase is not found to be clinically significant. So the dosing for Ipamorelin, again, is kind of, it's not truly standardized. We do find that most people like to use between 200 to 300 micrograms in the morning or the evening. So this one you can use in the morning or the evening dose. The SC50 in humans is about 150 micrograms. So, you don't necessarily have to start at 200 to 300. You could certainly start at 100 micrograms, and you got a lot of room to work up on. You certainly want to use the lowest effective dose to begin with. The cycles for this should be about 60 to 90 days. Maybe patients who are just starting on it, starting on a whole protocol, just fresh, that came to you new, you might want to cycle maybe for 8 weeks first on Ipamorelin, follow them, get their baseline before they start, and then just follow them for those 8 weeks. And you can go a little bit longer, maybe up to 90 days, and then cycle them off for a month or so, and then restart them. You need to give it at least 2 to 3 months if you're going to see any benefits that are reported there. It's unlikely that you'd see this, immediately within the first couple of weeks. You would definitely want to give it a 2 to 3 month trial to see these benefits in these patients. For patients who want to increase muscle mass, you of course want to use it in conjunction with Sermorelin or maybe even another GHRP. Some patients who like to use it maybe for weight loss, they can use it by itself at a little bit lower dose, of course with diet and exercise as well. So just some questions. I'm not going to read all this, but these are kind of for your reference a little bit later, but questions that came up on the last time, and I just included them in the slides here just so you can read them at your leisure. It has to do with a lot with cycling and some questions about physiologic and how it increases the number of somatotropes. And if you find it interesting, that's great. If not, we'll just skip over it. So we get to Ibutamoren, and this is the next drug we're going to talk about, and this is one of our newer ones. And the key thing about this is that this is not an injection, where everything we've talked about before must typically be injected to have the most beneficial effect. While you can give GHRPs sublingually, and they do show that there is efficacy in those, it's certainly not as effective as injecting a GHRP. And we'll talk on dosing a little bit later, maybe in your questions. But the great thing about Ibutamoren is that it's designed, and it is an orally active non-peptide growth hormone secretagogue, which means you don't have to give it sublingually. It doesn't have to dissolve under your tongue. You can swallow it whole. And this has been around for a number of years. It's not a new agent, that was recently discovered. This has been around for more than 20 years. It does stimulate growth hormone release through the pituitary and hypothalamus, but it does it through a different growth hormone releasing hormone receptor. It's they refer to it as a G protein coupled receptor that has an unknown ligand. So they really haven't figured it out yet, but they do know that it works at a different receptor, subtype receptor, that Sermorelin acts on. I'm just going to go through some studies here because this one has been very heavily researched. There's a number of studies that show that it's been very effective at increasing growth hormone. All these studies are typically going to be short-term studies. So I get asked a lot, what about these patients who use it for 3-4 months, 6 months? Can they use it every day for a year? Those are going to be taken on a case by case, I think, as you follow them clinically. But all the data that I'm going to present are typically, keep in mind that they're short-term trials. No clinical trial is going to go on for 2 to 3 years using these agents. So this is a 7-day treatment in very young men, 18 to 30 years old. They gave them doses of 5 to 25 milligrams at night, and their BMIs were between 20 and 23. So these are very healthy, thin, probably athletic men. And they increased their growth hormone pulse frequency as well as the number of low amplitude pulses. They nearly doubled. Their IGF-1 values up by 40%. 24-hour growth hormone secretions was 30% greater than that found in the placebo. And they did find that it helped them sleep and increase their REM sleep by 50%, as well as decreasing their time to reach REM. Another study here that was done for 2 to 4 weeks in the elderly. So these are kind of maybe somewhere around the patient population that we like to treat. Their IGF-1 concentrations were increased by 55% just at 2 weeks, and then almost to 90% by the end of the month. They almost doubled their 24-hour growth hormone concentration at the end of 2 weeks. They increased their growth hormone pulse height as well as their interpulse nadir. So they maintained that their baseline level basically just was maintained at a higher level. So this is attributed to an enhancement in a pre-existing growth hormone secretion potential that was already there that they did find. But they do know that their average growth hormone levels at baseline was about 140. At 2 weeks, it went to 220, and by the end of the month, it was up to 265 on average. So again, this is shown to be very effective in these patients, in the patient population, both young and old, where you can greatly increase your growth hormone levels in a relatively short period of time. The next study here is it's a 9-week study. This one has a little bit more people in it, almost 200 people. They're 65 years and older. And I include this study just because, bone density and bone strength in the aged is associated with a lot of morbidity. So it's important that patients keep their bone strength up. And, you add Ibutamoren to somebody who's who has risk factors for bone loss. This could be another therapy that you add on there. So This has been shown to stimulate osteoblasts, which of course build up the bone. Has been shown to increase this N-telepeptide crosslinks, which is a marker for bone resorption. It increases osteocalcin as well as the BSAP, which is an indicator for bone formation. So it increased all those values pretty significantly with a p-value of 0.001. They had an increase in IGF-1 serum concentrations, 85% at 2 weeks, 3% with placebo, and nearly doubled their IGF-1 by the end of the month. The side effects in this study, of course, were some musculoskeletal pain, 14% reported, which it probably isn't that significant considering that 11% of the people with placebo had the same complaint. Hyperglycemia, this is about 5 to 10% increase from the baseline, so slight increase, in your glucose levels. The elevated LFTs that you see during therapy are reversible. They're 1.5 to 2.5 times the upper limit. Typically, we don't really get too concerned about this unless it's more than 3 times of the upper limit. But again, these are transient in nature, and they do decline back to normal baseline after discontinuation. The prolactin was a 27% mean increase from baseline. And it sounds like a very large number, but they do say that a 27% increase, statistically significant, but certainly wouldn't be clinically significant in this particular patient population. So they had a little dose range study with this study. They did 10 milligrams or 25 milligrams for 2 weeks. They did 25 milligrams for 2 weeks and then 50 milligrams for 2 weeks. And then they also did between 5, 10, and 25 milligrams every day for 2 weeks, and then 25 milligrams every day for 7 weeks. So some of these patients were on this for a total of 9 weeks, and their IGF-1 was increased by 68% versus a minus 4% with placebo. So again, this study is kind of twofold, just to show that it does increase IGF-1 values and growth hormone values, but also that it can help increase the strengthening of the bones in your elderly patients. This one's a little bit longer. This is a 60-day treatment, and it's in obese young males. And I don't intend to use this study to show that it helps lose weight. That's not the intention of this study, to show that it can be a dietary supplement for weight loss. And I think some clinicians took that away last time, but I want to make it clear that I only use this information for this study to show that it is effective, very effective at increasing IGF-1 values, even in obese patients, because like we said earlier, that the growth hormone is blunted in obesity. So to have this effect, even in obese patients, is very promising. It can be very useful clinically. So we find that these patients were typically between 20 and 50 years old. They had a BMI that was over 30, and they were taking 25 milligrams a day. They did find that there was no statistically significant weight loss in these patients. However, when you read the study, you know that they were not told to change their diet. They were not told to change their total calorie intake. They were told not to change any level of physical activity that they did. And all patients in this study, whether they took the medication or they didn't, they all gained weight. So, of course, these patients that are typically obese to begin with, and you tell them not to change anything in their lifestyle, they're typically not going to lose weight. So it's not surprising that these people didn't lose weight. But it does go to show that it can be very useful. The use of Ibutamoren in obese patients can still have a great effect on increasing IGF-1 values, whereas the use of Sermorelin and things like that may not have quite a strong effect as this does. And this is one of the longest studies, the 2-year study in elderly patients, which is very valuable for our patient population. So it's a 24-hour mean of growth hormone increased by 80%. IGF-1 values up 50%. They were sustained within the normal range for a young adult in about half the patients who went under the study. Adverse effects of this, they had increased appetite, 31%, greater than the placebo, some transient edema, muscle pain, and then some joint pain. So this is these adverse effects, they do come with the medication, and then they're transient in nature, so then they go away upon discontinuation. And again, just some questions that came up during last time. Should the prolactin be monitored? Do the side effects that you see in this, they're going to resolve within 2 weeks or 30 days? And then we had one patient or one clinician say that their testosterone levels started falling after they started using Ibutamoren. So I give a little bit of information there in regard to that you can kind of read. And then there's, of course, the literature references in the back that we get to. So just some more frequently asked questions before we get to the questions that I think you all want to ask. So minimum amount of time a patient should take before they see results. Like I said, you can want to give it at least 60, probably better would be 90 days before you start feeling any of these benefits. So to go into therapy, you really need to set expectations. And if a patient doesn't see the changes that they hope for, you have to kind of weigh their expectations with what they're seeing. So, and then evaluate those to see if they're, a good fit, and maybe even what your expectations are as a clinician in some of these patients. And a lot of changes that people see are going to be quite variable between patient and patient. Even though you have two very similar patients, they're not going to have two responses the same way. So it's very challenging sometimes to dose these medications because your expectations just by default begin to be what they are. So the IGF-1 labs didn't change, or now they've begun to decrease. And we do find this happen after 3 to 4 months of continued therapy, particularly if they're using a GHRP at more than 100 to 150 micrograms. If they're using that high-dose GHRP, we do find that you get a little bit of resistance or tachyphylaxis, which can result in a decrease in IGF-1 levels. And are these FDA approved? There's no compounded medication that's FDA approved. However, as I mentioned, Sermorelin was an FDA approved product in the 90s for pediatric growth hormone deficiency, but was shortly thereafter discontinued. We use the same, Medicaid. We use the same, molecule. It's the first 29 amino acids of growth hormone, releasing hormone. Ibutamoren, has European and U.S. orphan drug status. It's under the trade name Oratrope. Like I said, it's been around for a number of years. It's been used for growth hormone deficiency, and it's been used in clinical trials here in the U.S. for the treatment of fibromyalgia. And there's an interesting study on that if you'd like to read about that a little bit later. And in that, I'll just give some time for some questions. I think I'm at my 45-minute mark, so I'll take some questions now if any of you have them, and I'll do my best to answer them.
Thank you, Tony. My name is Jennifer Gomez. I'm the marketing manager here at Wells. We do have some questions coming in. You can go ahead and submit them in the chat section, and I will read a few off to Tony. And if we don't get to any of the questions today, you can feel free to email us at info@wellsrx.com, and Tony can answer all your questions. So Tony, we'll begin out with one of the questions. In regards to patients currently under the treatment of CBD or cannabis, should any adjustments be taken into account?
That's a very relevant question. That's the CBD, is certainly gaining ground for therapy, and I really appreciate the question. I don't have any information, nor has there been any clinical data regarding the use of any CBD product, with these products. So, clinically, I really can't answer that question. But just, knowing how the medication works, I wouldn't suppose there would be any interaction with the CBD with these medications. But again, you'd have to do that monitor your patient and maybe observe clinically, how they're responding. But um, my instinct tells me that there would not likely be any issue with those patients. No.
Okay, we have another question. I apologize if I pronounce this wrong, but in a patient suffering from type 4 Ehrlich-Danlos syndrome wanting to take Sermorelin, particularly for skin issues, any particular recommendations?
Well, I have to confess, I'm not quite up to speed on my Irwin-Dolphin syndrome um, pathophysiology, so I'm really not quite sure what that stems from. Um, so I would have to get back to you on that one for sure. You could email that question in, and I can tell you what I can find. But a lot of these medications, clinically, the pharmacologic mechanism by which they work, are very unlikely to interact with many medications of that don't, of course, have an endocrine function to them. But any other medications, I wouldn't think would be a problem. As far as the issue with the skin condition, again, I'd have to just kind of do a little bit of digging on that. So I apologize, I can't answer that one directly.
Now, what is the typical dosing seen with Ibutamoren, and then does it make sense to titrate up for the first 30 days to avoid water retention?
Yeah, I think it's always best in the interest of the patient, just clinically to, we often promote 25 milligrams. That's the dose that's seen to be most effective in the majority of users, but certainly those we have clinical studies and medical literature that show that 10 milligrams was just as effective. I wouldn't say just as effective, but still very effective. So starting off somebody with a half a tablet to begin with, isn't a wrong thing to do, and could very well be provide the patient with some very good results. Titrating them up is always a very safe and conservative approach, and I think if I were to start this medication myself, as much literature as I've read about 25 milligrams being a good dose, I'm a little bit I'm on the side of conservative, and I would be more inclined to maybe start with half that dose, kind of see how I respond, and then adjust accordingly. So a lot of patients, though, you already can. I mean, you already know you're going to need 25 milligrams because their IGF-1 values are maybe 100, and they've got a lot of other maybe some obesity going on, or other medical issues. So in those patients, I don't think starting low and titrating up is warranted. But certainly in your regular average 20 to 25 BMI patient that's in their 40s, starting low and working up isn't a wrong approach.
Now, someone wants to know, do you have any experience with sarcotropin, and how might it compare?
I don't have any personal experience with sarcotropin. I do know that sarcotropin does contain GHRP2, and as well as some other vitamins and things like that that have shown to be, at least slightly effective at increasing growth hormone. The issue with the sarcotropin, you're to use that orally, but it's not just something that you use orally and swallow. You place it under your tongue and have to hold it there for several minutes to allow for the absorption, hopefully of the GHRP2. So, I don't really have any advice on whether you should or shouldn't use it. I think using it surely wouldn't hurt, and if you get good results from it, great. But if you're not reaching your goals of therapy, certainly I think moving to an injectable product would probably be, more efficacious.
Okay, thank you. And we do have a lot of questions coming in. If the slides will be available afterwards, we will send out a recording of this webinar with the slides. You should get that tomorrow. So if you missed any part of this, if you had to jump on late, you will be able to listen to everything. Now, someone wants to know, do you have any information on Sermorelin?
I do have information on it, but they're the clinical nature. But it's if you're talking about stuff that we're going to provide and things like that, it's not anything that in the foreseeable future that I think Wells will be providing. I don't know that it has any more advantage over Ibutamoren. But if you'd like to have some information, if you're just looking for something, I could pull something and then send it your way, sure.
Now, someone wants to know, what is the optimal range of IGF-1 considered safe to stabilize a level at, and what level do you not want to exceed?
That's a lot of age and age, sex, and patient variability. But typically, the ideal, I think, if you look on any chart anywhere, you're going to find that quote normal range for a specific age group can be very, very broad. But generally, most of the time, a lot of users will get their IGF-1 values in the mid hundreds, maybe upper hundreds. I've seen some go as high as a little bit over 200, but there's been some reports, and a lot of clinical data that sustained high levels of IGF-1, can be, mitogenic in some patients who are prone to it. So to say that all patients should be over 200, is a fallacy. So what's good for one patient, even if their IGF-1's at 150 or 160, if they came up from 120 and they're at 160 now, and they're feeling great, then that's their normal. That's good for them. There isn't a number that's your goal, and like I have to get these patients over 250. That's really that treating that number concept. It really isn't a good approach to therapy. You really want to take your patient into consideration and look at how their quality of life and how they're moving around, how their exercise recovery is. Are they losing inches? Do they feel better? Do they have more stamina? Things like that. And even if their IGF-1 level only went up 30 points, but they're feeling a whole lot better, then you've got success. Even if it doesn't matter if their IGF-1 doesn't get over 200. So really, you got to take that patient by patient and look at what their baseline is, and then set a real expectation kind of for that patient. And they might not meet that number expectation, but if they come back to you in 2 or 3 months and talking about how great they feel, and their value only went up 20 points even, then you got a success on your hand, and you got a return client. So just looking for that number, I think you kind of get lost in the number things rather than looking at the whole clinical picture of the patient.
Now, someone wants to know, does it make sense to rotate the following treatments? Sermorelin for 4 months, Ipamorelin for 4 months, Ibutamoren for 4 months. And can the body get used to one where it becomes not as effective?
There is, in regard to Sermorelin, I don't know if you get as much tachyphylaxis or resistance with that one, but you certainly can with the GHRPs. So that one, you would certainly want to kind of take a break from. I think the protocol that was outlined there, wouldn't be. I don't think there's really any wrong protocol that you could do as long as you're maintaining decent doses and taking regular breaks. I don't necessarily say I would use Sermorelin by itself initially. A lot of patients who are new and trying to get their growth hormone levels up, the use of Sermorelin at the very start, like from a de novo standpoint, Sermorelin may not always elicit the most prominent response right away. Certainly using something like the Ibutamoren initially would would spark that, and then jumping on board with a GHRP to help sustain that level. They all work through a little bit different receptors, so you're not going to get resistance, between the three of those. But certainly by using GHRP for several months, it can contribute to that. But that protocol that you just laid out sounds reasonable, but you'd have to take it patient by patient to see how they respond to that.
Now, someone said with their experience with Ibutamoren so far, 60 days of 25 milligrams nightly, their patient had an IGF-1 go from 129 to 268, and now the provider is reducing maintenance dose due to longer half-life to 4 times a week to 7 times a week. Does that make sense to you?
They went from taking it 4 times a week to now 7 times a week? I didn't understand that last part.
No, they were doing it 7 times a week, now doing it 4 times a week because their IGF-1 went from 129 to 268.
Right, yeah. So, as described in literature, IGF or Ibutamoren does promote a very pronounced and rapid increase. Certainly cutting back on that, taking it 4 times a week, that's a good protocol to follow. If you're finding that their IGF-1s are just getting too high, maybe for your liking. There's a number of different approaches you could take to that, I guess. But starting there by just decreasing a few days a week is a decent start, I think. You can find out, at the end of the next after 4 weeks of that to find out where you're at, and then kind of adjust accordingly. But it doesn't surprise me that it jumped up that fast. Sure.
Okay, I think we have time for one last question. Now, someone asked, which therapy do you feel is the best overall to optimize IGF-1 with little movement? They're guessing Ibutamoren with long-term body fat reduction.
Okay, so with Ibutamoren, I don't know that you're going to get a lot of body fat reduction with that. I mean, again, there's a lot of factors that go into this, and I think just looking for one of these medications to reduce body fat might not be, the right approach. But certainly you can increase, your lean muscle with this a little bit by having your IGF-1 values up. But not entirely sure about that for weight loss. If that was the question. I haven't found any research that shows that it's been effective for weight loss.
Okay, well, thank you so much, Tony. And if anyone has any other questions that they think of or we didn't have a chance to answer, feel free to email us again at info@wellsrx.com. You will get an email from us of the recording of the webinar tomorrow. And thank you all for joining. Thank you, Tony.
All right, thank you.
Bye.
Bye.